I think I'm about to be severely attacked by Jay after my talk. We've just heard a great talk, and look, I agree. I've used tantalum a lot, and my talk is not so much on the materials, but rather how you're going to reconstruct your options. Again, these are my declarations. So we know that osteolysis induced from wear particles remains one of the biggest causes for late failure and reason for revision. And my first two take-home messages are firstly that acetabular bone, being predominantly cancellous in nature, seems to be particularly vulnerable to osteolysis. And so you often get a lot more bone loss than what is appreciated on plain X-rays, and so you need to go on and do further imaging. And what's more also, with uncemented cups, you can in fact have quite significant bone loss and yet still have the implant well fixed. So often these patients remain asymptomatic even in the face of quite extensive osteolysis. And so again, the second take-home message is I think you really need to follow these patients up intermittently or at intervals to look for this phenomenon, because they won't have any symptoms or represent. But anyway, on to reconstruct the acetabulum. We're all familiar with the Proposky classification, well accepted, good for reporting on or comparing our results. But from a practical point of view, when I approach these cases, what I'm trying to think about more is not so much where are the bone defects, but rather where is the good bone that I can attach my new implant or reconstruction, because in the end the critical components are that I get good initial stability with the potential for long-term biological fixation or ingrowth. And so I'm looking for what host bone I have to support the implant and where is the viable bone. So how I try to classify it in my mind is the acetabulum that's remaining supportive or non-supportive of a cup, and is that bone viable and have the potential to ingrow into the surface of the implant that we put in. And it's pretty simple when it's supportive and good bone. We just put in a hemispherical cup supplemented with screws. It's when we have more extensive defects that we may have to go to more specialised techniques. And these are the non-supportive acetabulums I talk about, which are your Proposky 3A and 3B, and also pelvic discontinuities. And this is where we use more specialised techniques. As Jay has pointed out, the tantalum cups, or the highly porous cups, have really transformed our ability in these situations to achieve our surgical goals in revision surgery. Through their high porosity and scratch fit, they give us good initial stability. We probably don't have to have quite as much bone contact as we did with the titanium cups. And so we're able to get good biological with a high potential for biological fixation because of the modulus elasticity and the bone ingrowth potential. And what's more, when you combine them with augments, they extend our host bone contact, bypass the defects. They obviate the need to use large structural bone grafts or extensive bone grafting, and you really get a nice stable construct in good viable host bone, and you go home with a nice feeling that you've done a good job. This is where I may get attacked a little bit. So we've been starting to use recently a porous titanium cup recently. The difference being here that these cups are actually 3D printed from CT scans of human cancellous bone. So the structure is meant to mimic the cancellous bone. It has a structural strength which is somewhere in between cortical and cancellous bone, and so the belief is that the loading of the bone, the strength of the bone, will mean that the loading of the surrounding bone will be optimized and give the good potential for bone ingrowth. And one of the unique features of this cup is that it is a one-piece construction. That is, it's 3D printed rather than applying the porous coating to the titanium. And so by an additive manufacturing process, the cup's all one piece. And what does this mean? It means that you can actually have a thinner cup without having to add the porous coating after. So is this really an advantage? Well, maybe. But what it does do, it does mean that you can have a slightly thinner shell with perhaps a better or more optimized head to cup ratios, which means you can get bigger heads into slightly smaller cups. And given that one of the commonest complications after revision surgery is instability or dislocation, perhaps this does give you an advantage in using bigger head sizes, more liner options to deal with this potential complication. When the acetabulum is unstable, that is, have a pelvic discontinuity, then what I tended to do, or my treatment of choice, was to use an acetabular reconstruction ring traditionally, because you've got to not only bypass the defect, you've got to stabilise the actual unstable pelvis. And this was my treatment of choice up until recently. I think if you're going to use cages which traditionally have had a bad track record, it's very much like treating a fractured bone. It's a race between the acetabulum healing versus the cage fatiguing. So cage design does make a difference. So I like to use this cage, which is 4 millimeters thick, which means it's a little bit thicker than the Birch Schneider cage. It is made of titanium, so perhaps a little bit more flexible. And it does have a porous coating on the back surface, which means it does have the potential for the cage to actually ingrow and incorporate within the whole structure. They are technically quite difficult. I find it very hard to get good bone contact here superiorly on the ilium, but at the same time getting good fixation inferiorly into the pubis. And it's really important to get fixation down here, otherwise your cage will tend to flip out. My preference is to impact this spade into the ischium, and as I say, it is actually technically quite difficult to impact this into the ischium and then at the same time bring the cup down onto the bone here, but it's very important to achieve that. Additionally, you want to have screws that are both transverse in the wings as well as vertical screws in the dome and peripheral rim. But if you can achieve that, it does provide you with a very stable construct in a potentially difficult situation. And as I say, if you get good bone graft and it heals, then there's no reason why it shouldn't give you a long-term solution. But I have to admit, more recently, my use of cages has decreased with the availability of these custom 3D printed tri-flange cups. The biggest advantage of these is it's patient specific. That is, you optimize host bone contact as well as the filling of your defects with the implant itself. Whereas the other implants, you're trying to make the implant fit the bone, where you're trying to make the bone fit the implant, which means that you often have to take more bone away to make it fit. Whereas with these implants, you're doing the opposite. You're making the implant fit the bone. And so it's done via imaging studies, a CT scan. The process is that the CT scan software allows you to remove the old implants, look at what defects you're left with, or more importantly, as I said, what bone is available, and planning your implant on the remaining bone. What's really nice is also you have the ability to individualize your screw positions, your screw trajectories, and also pre-plan your length in safe zones, so that it's just a little bit more, safer and reassuring that you're not going to hit any critical structures. And additionally, these flanges on the cup are thick enough that you can incorporate locking screws into it because you have enough room to add a thread. And these really improve the stability of your construct. You do also get a sterilizable plastic anatomical model, which is patient specific. You can leave it on the setup. It allows just to assist you with your exposure and getting your implant fit. And whilst the exposure is quite extensive, because you're dealing with big defects, once you do expose it properly, the implants do fit very nicely and are quite stable, and it gives you, as say, a stable construct. And this is the sort of result you hopefully end up with. So in conclusion, I think revision surgery normally involves the acetabulum. Acetabular reconstruction can be challenging because of the amount of bone loss that you're often faced with and have to reconstruct into. But if you can get a supportive construct with good biological capacity for ingrowth, then you should hopefully end up with a long-term stable construct and long-term good result. Thank you very much.